Let's say in the ideal world, actually every CT chest should be gated. However, this is not always possible. If there is a low index of suspicion for an acute aortic syndrome, then you may opt for a non-gated, non-enhanced CT chest and a non-gated CTA chest. It's important for the radiologist to be available for real-time review so that he can troubleshoot and maybe add an ECG-gated study if there's any ambiguity. MIP reconstructions, MPRs, and 3D VRs are done routinely, which helps in the interpretation of the images. So this is just an example of how important ECG gating is. In the first example on your left, you can see that there's soft tissue density anterior and posterior to the ascending aorta. It is impossible to know whether this is pulsation artifact or which is often referred to as pseudodissection. And in this, on the same patient, the study was repeated with gating, and you can clearly see that there is a mediastinal hematoma, which is an acute emergency and needs urgent surgical referral. No pre-medication is necessary for this imaging study, and dose could be saved by using prospective ECG gating, by using dual source prospective high-pitch ECG gating, and in patients with a BMI less than 30, you can decrease the KVP. So in 2010, these acute aortic syndromes were classified into 5 different classes. Class 1 is the classic aortic dissection. Class 2 is intramural hematoma. Class 3 is limited intimal tear. Class 4 is penetrating atherosclerotic ulcer. And Class 5 is iatrogenic and traumatic dissections, which I'm not going to discuss. So let's get started with Class 1, the classic aortic dissection. So this is a tear in the intima of the thoracic aortic wall. And then there is disruption of the media with bleeding in and along the wall of the aorta, which results in true and false lumens. So the most important part of the radiologist is to accurately classify these lesions because that determines the management. And when there is involvement of the ascending aorta, it is classified as Stanford type A. The Stanford classification is currently the most widely used, and that is what I suggest that you use. So this image demonstrates a type A dissection. You can see there's a primary intimal tear in the ascending aorta, and there is the dissection flap involves the ascending aorta. Then type B is the example over here, when there is involvement of the thoracic or descending aorta distal to the left subclavian artery. And important, there is no involvement of the ascending aorta. Also important to note, your classification is based on the extent of the intimal flap, not the primary entry tear. So you could have a primary entry tear in the descending thoracic aorta, but if this flap extends all the way proximally to involve the ascending aorta, you would classify this as a type A Stanford dissection. From this, you can gather that I've said when it's a type A, it involves the ascending aorta. When it's a type B, it involves the aorta distal to the left subclavian artery. So we have not touched on the aortic arch. So this is actually not accounted for by the Stanford classification. And the way that I suggest we address this and how the cardiothoracic surgeons address this is they still refer to it as a type B, but they call it a type B with aortic arch involvement to be clear exactly what is going on. So these are 2 examples. One is of a Stanford type A dissection. You can see the dissection flap in the proximal ascending aorta. The flap extends into the brachiocephalic artery, which is important to note. And at the bottom is an example of a type B aortic dissection with involvement of the thoracic aorta distal to the left subclavian artery. This is an example of a non-enhanced scan where you can use the displaced intimal calcifications to suggest the diagnosis. You can see the intimal calcification is displaced towards the right, and the contrast-enhanced scan clearly demonstrates the intimal flap in keeping with a type B dissection. These are examples of patient. This is a patient with a type A dissection, proximal dissection in the proximal aorta with an entry tear, and there is a re-entry tear where there is communication between the true and the false lumens. In this example, this patient does have multiple re-entry tears, and this is important to the cardiothoracic surgeon as he may plan stenting, and he doesn't want to occlude all the entry and re-entry tears as that may lead to malperfusion syndromes. 2 signs described to help differentiate the true lumen from the false lumen. Bottom image, you can see that there is thrombus in this lumen, and this is typically the false lumen, as there is remnants of the adventitia which forms thrombi, and that helps indicate that it's the false lumen. The second sign is called the big sign. You can see the big sign anteriorly, and that is because the false lumen doesn't have a good outflow. So the false lumen is constantly under systolic blood pressure, and that's why the false lumen is typically larger than the true lumen, because of this constant systolic pressure. The natural history of aortic dissections is most commonly in the ascending aorta, and the majority of type A's actually lead to mortality if they are unrepaired. These are examples of complications of type A dissections. You can see that there's rupture of the ascending aorta, there's the intimal flap, there's an associated hemomediastinum, there's also associated hemopericardium, as well as bilateral hemothoraces. And this is really, really important. If you read the scan and the patient does have an aortic dissection, if you see fluid in the thoracic cavity, it is not a pleural effusion. It is most likely a hemothorax until proven otherwise, and this should be suggested by the radiologist as a sign of rupture. This is just a nice example of a patient, again, with a type A dissection. There is extension of the hematoma or the dissection into the aortic wall, and you can actually clearly see on the non-contrast study that this hyperdensity actually also extends along the pulmonary artery, because the aorta and the pulmonary artery share a common adventitial sheath, and you can clearly see on lung windows how this hemorrhage extends along the interstitium in the perihilar zones. Important to comment on involvement of branches, as the dissection flap may extend into the branches. There's involvement of the greater vessels or the aortic branches, involvement of the SMA in this case, involvement of the left renal artery in this case, which typically arises from the false lumen, and also involvement of the iliac vessels, which would be important if this patient is considered for endovascular repair. This is just, again, an example of the increased size of the true lumen because of this constant systolic pressure. This true lumen may actually, the false lumen may actually completely compress the true lumen, which would necessitate urgent fenestration of the intimal flap. So when I have a patient with a suspected dissection, what do I report on? What do I think is, the clinician really wants to know from me? I comment on the dissection extent. So is it a Stanford A or B? Is there aortic arch involvement if it's a type B? The site of the entry and the re-entry tears. Differentiation between the true and the false lumen. To comment on aortic valve and side branch involvement. If there's any signs of end organ malperfusion, for example, the kidneys. And also on the morphology of the vessels if endovascular repair is contemplated, and then signs of rupture, which is really important. So typically, as we've mentioned, and as I'm sure we all know, how these conditions are treated, type A is immediate surgery when there's involvement of the ascending aorta, and type B is conservative treatment unless it's a complicated case, meaning persistent hypoperfusion or low blood pressure, persistent pain, and any signs of malperfusion. So there's a special type of a type A dissection, which is called a retrograde type A aortic dissection. It is when the entry tear is in the descending aorta with retrograde extension of the dissection into the ascending aorta. So we still call it a type A. The prevalence, it makes up 25% of type A's, and the management is controversial, but in recent times, endoluminal stenting have shown improved outcomes because there's often involvement of the arch vessels. So now that we've discussed aortic dissection, which is basically the prototype and the most common of these acute aortic syndromes, I would like to explain how I think of this. Aortic dissection is actually a spectrum. It's a spectrum comprising three conditions, called the classic aortic dissection as we all know it, the intramural hematoma, and the less well-known limited intimal tear. And all of these share a common underlying pathophysiological process, meaning cystic medial necrosis. So this process actually causes degeneration of the media. What happens next is basically the whole wall of the aorta expands. And it is postulated that the intima is the least resistant to this change in diameter. And then subsequently, you get a tear in the intima. So the primary pathology is actually in the media. So now, if you have this slightly expanded aorta with the weakened media and the rupture in the intima, 3 things can happen. Number 1, blood can go through the intimal tear and create a second lumen or a false lumen, which is the classic aortic dissection. Second option is there's probably a really small tear and there's no re-entry tear. So hemorrhage just seeps into the wall and basically forms an intramural hematoma. Third option is where you have a tear in the intima, but this blood actually does not dissect into the media. So all you have is that little focal tear in the intima and then mild bulging of the aortic wall. All you'll see on imaging is a little contour deformity in the aorta. And all of these, because they share the same pathophysiological process, they can all coexist in the same patient. So we'll quickly address the other types. Intramural hematoma, it's a crescentic or circular thickening of the aorta without dissection, flap, or obvious entry tear. There's no flow in the false lumen, and the classic teaching is or was that it's a result of rupture of the vasa vasorum. But more sensitive imaging modalities have shown that there is intimal tears in many cases of intramural hematoma. This is often found during surgery, and at autopsy, 96% of patients with IMH has little intimal tears. So all of these findings suggest that IMH may originate from small intimal tears rather than the classic teaching of rupture of the vasa vasorum. As we've said, IMH is a variant of AD with the underlying pathology being in the media. Their risk factors classification is the same. They almost get treated the same. And as we said, they may coexist. This is imaging of a intramural hematoma. We do the non-contrasted study to detect this. You can see this crescentic hyperdensity in the descending aorta, and it extends longitudinally along the aorta. One thing that I find helpful in differentiating a intramural hematoma from dissection is the hematoma kind of maintains this constant relationship to the aorta, where a dissection will often spiral, the false lumen will spiral around the true lumen. And then this is followed by a contrast injection to evaluate for the intimal flap or possible dissection. And in this case, there was none. But this just shows that you could easily miss an intramural hematoma if you do not do the pre-contrast or non-contrast study. And this is a nice, I think, example explaining that this is all a spectrum of diseases. This case demonstrates the hyperdense crescent, the intramural hematoma. And this is a contrast study which shows minimal leakage of blood into this hematoma. If you probably would have imaged this 2 days earlier, you might have only seen a hematoma. And maybe if you imaged this 2 days later, you would have only seen a dissection. You know, we're postulating, but I think that proves our theory. The complications of IMH exactly similar as dissections. That's why they're treated the same. This is an example of a hemopericardium and a tamponade being the big problem there. And the natural history of IMH, 35% may actually regress, 25% progress, and then some may expand into aneurysm and some may rupture. Risk factors are as listed below: type A, associated type or type A IMH, coexisting penetrating atherosclerotic ulcers, older age, and increased size. So the traditional approach to treat IMHs was, if it's type A, surgery, and type B is initial medical treatment. But recently, timed urgent surgery has been performed, where these patients are rather followed up with imaging, and if intervention is needed, it's done on a timed or slightly delayed basis. And the criteria for observation is basically hemodynamically stable, no pain, smaller size of the lesions, small pericardial pleural effusion, and no involvement of the aortic valve. This is an example of a 67-year-old gentleman with chest pain. Imaging reveals a type A intramural hematoma and a type B dissection, and 6-month follow-up imaging shows the regression of the type A IMH and the increase in size of the false lumen of the type B dissection, and this patient subsequently had stenting. So class 3, the limited intimal tear, is less well known, and this is because it's really difficult to see this. So it's a variant of aortic dissection, and it's just exposure of the underlying media, as you can see here, and then slight bulging of the wall. It's detected intraoperatively in 5% of patients undergoing aortic aneurysm repair, again suggesting that it's a spectrum. It's very difficult to see on non-gated CTA, and this is a nice example of a limited intimal tear. You can see on the 3D reconstruction, there's a little defect in the intima there, and there's then bulging out of the wall of the aorta with no dissection into the adventitial layers. Often you may see a small little associated intramural hematoma. The treatment, if ascending aorta is involved, emergency surgery and descending aorta endovascular therapies could be considered. So class 4 of the acute aortic syndrome is different than the first 3. The penetrating atherosclerotic ulcer, it's a lesion in the intima, because atherosclerosis, the process typically occurs in the intima, and this is where it starts. And then there's ulceration that penetrates the internal elastic lamina and then goes into the media, and then may result in associated hemorrhage in the wall of the aorta. It most commonly involves the descending thoracic aorta, and you may have multiple ulcers in up to 30% of patients, and this is because these patients do have extensive atherosclerotic disease. The majority is uncomplicated. It's often associated with IMHs when this lesion extends into the media, and it may progress to larger size, pseudoaneurysm formation, and the feared complications is dissection and rupture. Risk factors for progression. Overall, 40% of them progress. The proximal location, increased in size, coexisting intramural hematomas, pain, and a large pleural effusion are risk factors. Treatment, again, if the ascending aorta is involved, surgery is indicated, and if risk factors present, then if it's the descending aorta, then instant endograft treatment is used. And we often classify these also with the Stanford classification, type A and type B. This is an example of a 72-year-old gentleman with severe progressing chest pain. He initially presented on the non-contrast study with a intramural hematoma. The contrasted study revealed a small penetrating atherosclerotic ulcer, and this was 3-month follow-up imaging, which shows significant increase in the penetrating atherosclerotic ulcers, and this patient was then treated with a TVAR because of progression of the ulcers. So this is a nice table that was published by the British, and that basically this is the clinical or risk stratification for acute aortic syndrome. So they look at 3 things. They say if a patient enters the ED and as is suspected of having a dissection, if the patient has any high-risk conditions, which is like connective tissue diseases or aortic disease, or if there's the high-risk pain features that are present, which is typical of this acute aortic syndrome, meaning that it's abrupt in onset in severity and that it's got this ripping, tearing, sharp nature. And also if the patient does have worrisome findings on clinical exam like pulse deficit, focal neurological deficit, you look at these 3 things. If none of them are present, this is a low-risk patient, and you proceed with other diagnostic considerations. If this patient does have any one of these features present, he's intermediate risk. And then you do basic tests like ECG to exclude acute coronary syndrome and a chest X-ray to look for alternative diagnoses. And if these are negative and acute aortic syndrome is still the most likely diagnosis, then you proceed to your CTA. If any 2 or more features are present, you immediately contact the cardiothoracic surgeon and you perform your CTA. So basically, in summary, acute aortic syndromes encompass a disease processes that primarily affect the media, such as the aortic dissection, intramural hematoma, and the limited intimal tear, and then also of the intima, where the PAU starts. But the penetrating atherosclerotic ulcer also involves the media at a slightly later stage. The different types of acute aortic syndrome can coexist because it's, as we've said, the spectrum of these diseases. And I hope I've convinced you that ECG-gated CT is critical in the detection, preoperative planning, and surveillance of acute aortic syndrome, and that on the horizon is more conservative management because it shows promising results. I thank you very much.